presenting a treated case of carcinoma of breast with recurrence. 30 years young lady, married, nulliparous, non-diabetic, normotensive, without any family history of malignancy. Presented a lump in the right breast and axilla in 2017. Core biopsy from right breast lump showed infiltrating ductal carcinoma grade 2 and immunohistochemistry report showed ER positive, PR positive and HER2 negative. Her clinical diagnosis was T3N1M0. Then she treated with neoadjuvant chemotherapy with injection doxorubicin and injection cyclophosphamide 4 cycles from October 2017. Then she underwent mastectomy with axillary clearance on January 2018. All lymph nodes showed reactive changes. Then she treated with adjuvant chemotherapy with injection docetaxel up to April 2018. She also treated with radiotherapy 50 grade 25 fraction up to June 2018. Then she was taking tablet tamoxifen since June 2018 for 3 years. Her follow-up period was uneventful for 2 years. And unfortunately, she was positive for COVID pneumonia and admitted on December 2020 with metastatic breast cancer with pleural effusion left. On that time, her PET CT scan showed no evidence of recurrent mass, newly developed soft tissue density, enhancing superior and anterior mediastinal mass with FDG uptake 22.2 with mediastinal lymphadenopathy, which suggests disease progression. Here are some slides of PET CT scan. Then she underwent tube thoracostomy left with streptokinase on January 2021. Then ultrasound-guided pleural lobulated left-sided aspiration done twice on January and February 2021. On that time, her pleural fluid cytology showed negative for malignant cell. On the last of January 2021, core biopsy from mediastinal mass left showed metastatic ductal carcinoma and immunohistochemistry report showed ER/PR HER2 negative. And chest CT scan showed suggestive of mass lesion at left upper lobe measuring about 88 into 67 millimeter with huge pleural effusion with passive collapsed and consolidation at left lung. Then she treated with palliative chemotherapy from February 2021 with nab-paclitaxel and carboplatin 3 weekly at day 1, day 8 basis. After initial 3 cycles, the response was good and mid-cycle evaluation with CT scan showed reduction of bulk of the lesion about 67 into 48 millimeter. Large collapse with significantly reduced vascularity amelioration of disease process. Large collapse consolidation in left lower lobe with large insistent pleural effusion left. So she planned to continue 3 more cycles of same schedule and cycle 6, day 8 completed on June 2021. After that, on 6 July, breast and liver showed gross metastatic pleural effusion with evidence of extensive loculation and septation along with nodular thickening in left hemithorax, which was more prominent since May 2021. Collapse of left lung field with suspected infiltration soft tissue within it suggests more aggressive. On July 27, core biopsy from left lung tissue showed pneumatic consolidation, and this review biopsy showed no malignancy at all. But unfortunately, on 12 August 2021, FNEC lung upper left showed metastatic ductal carcinoma of breast origin. Here are some CT scan film of this patient. Now, things need to be discussed. Review by one of the thoracic surgeon and opted for video-assisted thoracoscopic surgery associated decompression with high risk. any benefit for doing the surgery in case of recurrent disease of breast origin? What is the next line treatment option? Is that eribulin? Is there any role of CGP or BRCA testing for future directions? Thank you.
Thank you, Dr. Riya. Quite interesting case. Quick conversion from ER positive to triple negative, very short period of time. Young patient, very aggressive. Don Dizon, sir, what do you like to say?
Yeah, it's unfortunate. I always consider a young age with breast cancer a very poor prognostic marker, even for young patients with hormone-positive disease. Of course, we know tends to be far more aggressive. Yeah, I'm going to answer the last question first. Is there a role for genomic testing or BRCA testing? The guidance here in the United States is that everyone should be tested for BRCA at the point of a diagnosis of breast cancer. So yes, we would test. I think her young age would force us, but remember, it's also a therapeutic thing now. If there is a mutation in BRCA seen, it opens up an option for treatment here with PARP inhibitors, which I do not think is available in Bangladesh. For comprehensive genomic profiling, it is being done as well in the United States, where we have access to immunotherapy. The tumor agnostic indications are for mismatch repair deficiency, but also for high tumor mutational burden. And certainly I have a patient now who is progressing, and her genomic profiling showed no mismatch repair deficiency, low loss or no loss of heterozygosity. She was negative for PD-L1 testing, but she did meet the criteria for high TMB. So for checkpoint inhibitor therapy, that is a very important thing we're doing now. For hormone-positive disease, we're looking for PIK3CA mutations, much less relevant here. In terms of surgery, I kind of wasn't clear. Is this her only site? Is her lung the only site of disease?
I think I have to take over that answer the question. The lung is the only site because there is no other metastatic foci for local or other bony or brain disease so far.
Yeah, so yeah, that's unfortunate. I've seen this as well. She does have multiple options. What I've done if for folks who really need a response, because right now she's progressing on her treatments, I've used a platinum in triple negative disease to treat metastatic disease. I've used it with gemcitabine. So my choice for a rapid response has been cisplatin with gemcitabine. I find that to be effective to get people out. But I do think, other reasonable options, capecitabine, if she's able to, because it's an oral regimen, can be used. I don't know about eribulin right now, given she's coming off of nab-paclitaxel. It's essentially the same mechanisms of action for that drug. And in terms of is there any benefit for doing surgery? The benefit is palliative. It's not going to be curative for this person. I think the hard thing is, she has evidence of disease in her lung, but she's also coming off COVID. How much of this is just post-infectious changes in the lung? How much of this is malignant? That actually might be worthwhile to answer with a surgical approach. So maybe for more diagnostic clarity, I think if you put her through a huge surgery to basically resect the lung, I don't think that's indicated at all. But yeah, the other things I would think of is a local regional approach if it was possible at all. If after surgery you're able to debulk, then maybe some radiation. Perhaps we can have Dr. Balakrishnan talk about the role of palliative RT in this kind of setting, especially tempting if truly her disease is only involving her left chest.
Thank you, sir. Nicholas, your comment, please.
This is a very unfortunate case, and I agree that very young women such as this have a poor prognosis. She's recurred fairly quickly after her initial diagnosis. I would comment that we would typically give complete neoadjuvant therapy. So we'd do the anthracycline and taxane prior to the initial breast operation when they present with early stage disease. Did she have a good response to chemotherapy within the breast? Do we know because there were reactive changes within the lymph nodes, and whilst now we wouldn't give any post-neoadjuvant therapy if there's ER-positive disease, it may give an indication of anthracycline sensitivity to consider something like liposomal doxorubicin. She's already had carboplatin in the metastatic setting, so she's already had her first-line treatment. So I think that BRCA testing is well worthwhile, although the results of the Olympiad, I think it was the Olympiad trial.
Nicholas, we cannot hear you very clearly. Your voice is, keep it a bit closer at the microphone.
Yep. Yeah, I'll just keep the microphone a bit closer. The Olympiad trial, I think, was the trial that separated patients by line of therapy with the BRCA positive with the PARP inhibitor, olaparib, and found that first line olaparib was the best option. Likewise with immunotherapy. The earlier the immunotherapy is given, the better, and you'd want to see PD-L1 positive on IHC, and whether that's for pembrolizumab or atezolizumab, but typically they work better in the metastatic setting in the first line rather than later lines, and interestingly the results in the early stage don't rely on PD-L1 positivity. So I would consider eribulin at some point. I think that it is an active agent, particularly in the triple negative group. There was the trial looking at resection of the primary in triple negative breast cancer that showed that particularly poor outcomes for the triple negative group. I think that the comment here, I take it as being a comment about surgery for VATS decortication and pleurodesis rather than resection of the primary, but maybe I'm interpreting that incorrectly. And I also agree when something is triple negative and has gone on to from previously being hormone receptor positive, is that a different cancer? I mean, I think it's very unlikely in this situation, but that's something just to be sure of. And systemic therapy and potentially radiotherapy is the mainstay of treatment with this sort of situation, with a palliative approach rather than with curative intent, because this patient is not going to be cured of her cancer, unfortunately. And hopefully she will have some level of quality of life. So we aim for the minimum treatment required to maintain quality of life, as well as to control the cancer, and hopefully in this situation induce a response to help with her symptoms.
Thank you. Rajesh Balakrishnan sir. I think Rajesh sir is disconnected. We move on to next person. Salim Reza sir, are you there? We missed you last time.
Yes. Sorry, I got cut. Yeah. So what I would like is whether Dr. Khatija, as she pointed out, whether this patient had GATA and other things to rule out that it is not from breast.
I think the immunohistochemistry was done extensively for this patient to rule out that this is the breast organ, and unfortunately maybe not addressed here, but it was inclusively breast organ.
Okay. So another thing, as Don was Dr. Don was saying about the role of SAB here, this patient is not an ideal case for SABR in the current scenario because patient has pleural effusion and a mass which is slightly big. Maybe once the effusion settles or something, then maybe we should consider at that point whether the patient is eligible for SABR or not.
Okay, thank you, sir. Salim Reza, sir.
So in these stages, as the case, this lady is unfortunate. On the short period of time, this converted into triple-negative breast cancer. In these stages, we do some tests. Firstly, BRCA1 and 2. If it is positive, then we will go for the PARP inhibitor. And we can do also the PD-L1 test. If it is positive, then we'll go for immunotherapy.
One important issue regarding the thoracoscopy, video-assisted thoracoscopy for removal of that tissue for appropriate measure, because the FNAC revealed it's a metastatic lesion. But because it's a stage 4 disease, if we think that in that case we should not go for beds. But as last PET CT scan done on December 2020. But I think at this stage, if another PET CT can be processed, then if there is no other lesion except lung, in that case, thoracic surgeon is to be consulted for that and go for removal of that tissue and then search for whether there is the FNAC, what it is revealed in the FNAC report that has been the appropriate one. If there is no other lesion, then go for further antimycotic treatment in the form of other approach as per consultation with medical oncologist.
Actually, there is after the nab-paclitaxel has been given from February to June 2021, they found a new lesion in the left upper lung, that is the metastatic lesions. And at that time, the core biopsy was done in December when PET scan is done. And the core biopsy shows is a metastatic ductal carcinoma, and it was a hormone receptors negative and HER2 negative cases in that cases. So if it is a very interesting cases, and this case has already had a progress actually, and part of therapies has been given. I think, to my opinions, we should have a palliative treatments that can be the capecitabines, or even we can use the gemcitabines and platinum, especially. Though initially we have to use the carboplatin in these cases with an nab-paclitaxel, we can use the gemcitabine with cisplatin if patients can tolerate, because patient has in the meantime has performance status is not that much at the present moments. So that's my opinion actually.
Yeah, it's interesting. You know, the data just quickly for cisplatin and gemcitabine comes from a very small clinical trial in ovarian cancer, where patients were resistant to carboplatin, and there was still responses seen with cisplatin and gem. And I think the rationale is that gemcitabine can actually help reverse platinum resistance. So I would not retreat her with carbo, exactly for Professor Chowdhury's point. If you were going to try, I would go to cisplatin and gemcitabine.
I have some comment for because of my long experience of practicing here.
Yeah.
And my comment is for my junior oncologists and other juniors out there. In such a case, I think we should go for a longer panel, a broader panel, like CK7, CK20, TTF1. These should have been done in addition to GATA3 and GCDFP, because ultimately we found it as a triple negative case. So there is possibility always lies there. So you cannot take it granted that this is a case metastatic from breast. There may be another tumor anywhere. So there is some system to follow. So I think we should go through the system. We should do some more immunos to confirm it properly that this is from the breast, nothing from nowhere else. I think that is the thing. I am just talking from my own experience and for the junior practitioners.